Fentanyl is a highly potent, fully synthetic opioid first synthesized by Janssen Pharmaceutica in 1960. Clinically introduced as an intravenous analgesic in Europe in 1963 and in the US by 1968, it has since become one of the most widely used opioid analgesics globally. Today, fentanyl is the standard intravenous opioid for intraoperative analgesia. It is also widely employed in managing severe chronic pain, particularly in oncology, as well as in select non-malignant conditions. Outside of medical use, fentanyl has become a prevalent adulterant in illicit opioids like heroin. However, due to its extreme potency, approximately 30 to 50 times stronger than heroin, unintentional consumption frequently leads to overdose. As such, fentanyl is a key contributor to the ongoing opioid crisis in the US, Canada, and parts of Europe, including Estonia. In this video, we will explore the essential facets of fentanyl, from its chemical and pharmacological properties to its psychophysiological effects, beginning with a brief historical overview. The development and clinical deployment of fentanyl traces back to the Belgian pharmaceutical company Janssen Pharmaceutica, now a part of Johnson & Johnson. The company was founded in 1953 by Dr. Paul Janssen, a Belgian physician with a keen interest in creating potent, fast-acting analgesics to address the complex pain management needs of the time. At the time, morphine and pethidine were already in clinical use. Dr. Paul Janssen and his team hypothesized that the pethidine ring, a shared structural component of both compounds, was central to their analgesic effects. Rather than working with morphine, which had a more complex structure, the research team focused on pethidine as a more chemically tractable base for developing new opioid compounds. Their aim was clear: to engineer more powerful and selective analgesics with fewer side effects and broader therapeutic window than existing opioids. A key limitation of morphine and pethidine, as identified by the team, was their inadequate penetration of the central nervous system, resulting in slow onset and limited efficacy. In order to overcome this, they embarked on synthesizing more lipophilic derivatives, believing that improved fat solubility would enhance the drug's ability to cross the blood-brain barrier. Through strategic modification of the parent molecule, such as the addition or substitution of functional groups, they created a wide array of novel compounds. Many of these exhibited greater lipid solubility, faster onset, and enhanced analgesic potency. However, the team also recognized that lipid solubility alone was not sufficient. Binding affinity to the then theorized but not yet characterized pain receptors, what we now know as mu opioid receptors, was also crucial. Thus, additional structural modifications were designed to improve receptor binding, and each candidate compound was rigorously tested. Between 1953 and 1957, the Janssen laboratory synthesized dozens of such compounds, culminating in phenylpyridine in August 1957. This molecule proved to be 25 times more potent than morphine and over 50 times more potent than pethidine in animal models, making it the most powerful opioid known at the time. Phenylpyridine saw clinical use in many European countries as a rapid-onset, short-acting analgesic suitable for anesthetic purposes, although it was never introduced in the United States due to Janssen's lack of US distribution network. Encouraged by these results, the research team continued developing new analogues of phenylpyridine, and in December 1960 they successfully synthesized fentanyl. Fentanyl surpassed its predecessors in every meaningful metric. It was over 10 times more potent than phenylpyridine and 100 to 200 times more potent than morphine in preclinical testing. It also exhibited superior lipid solubility, rapid CNS penetration, the fastest onset of action, and the highest therapeutic index ever recorded for an opioid at the time. Following its introduction in 1963 as an intravenous analgesic across multiple Western European countries, fentanyl was frequently administered in combination with various intravenous sedatives and hypnotics throughout the 1960s and 1970s. These combinations were part of early efforts to develop total intravenous anesthesia protocols. Despite its growing popularity in Europe, Both as a standalone agent and in conjunction with drugs like droperidol, a dopamine receptor antagonist, fentanyl did not immediately gain traction in the United States. It wasn't until 1968 that the FDA approved fentanyl, after which it was marketed for use in combination with droperidol to induce sedation and anesthesia during invasive procedures. By 1972, fentanyl became available in the United States as a monotherapy, though initially only in vials containing 50 micrograms of the substance. The 1980s marked a pivotal period of global expansion in fentanyl use. This growth catalyzed several key developments: the emergence of novel fentanyl analogues, increased interest in other opioids, and the advent of innovative opioid delivery systems. Janssen Pharmaceutica led the charge, initiating the development of sulfentanyl and alfentanyl and collaborating with clinical researchers, including anesthesiologists and pharmacologists, to evaluate these compounds both in human patients and wildlife models. Among the earliest and most notable studies began in January 1980 at the University of Leiden in the Netherlands, where researchers launched investigations into alfentanyl and sulfentanyl. These studies soon extended across numerous medical centers in Europe and the United States and would continue for nearly 2 decades. Their work not only reshaped clinical practice surrounding fentanyl and its analogues, but also transformed broader approaches to opioid pharmacotherapy. This sudden surge in research also gave rise to the so-called suprafentanyls, extremely potent analogues initially intended for wild animal immobilization and counter-terrorism applications. The growing scientific interest further spurred companies like Glaxo to explore new opioid compounds, eventually leading to the creation of remifentanil, and prompted Anquest, a division of the British Oxygen Company, to develop additional synthetic opioids for wildlife and clinical use. By the mid-1980s, fentanyl's clinical application had broadened to include intrathecal administration as part of spinal anesthesia and epidural delivery for labor analgesia and surgical pain management. This period also marked the beginning of transdermal and transmucosal delivery innovations. Oral transmucosal fentanyl, initially developed for preoperative sedation and anxiolysis, would later find widespread use in managing breakthrough pain among opioid-tolerant patients. Before proceeding, it's worth briefly discussing the legislative history of fentanyl and its analogues. In this regard, fentanyl has been classified as a Schedule I substance under the 1961 United Nations Single Convention on Narcotic Drugs since 1964. Moreover, several structurally related fentanyl analogues were subsequently added to Schedule I as their abuse potential became evident. Notably, sulfentanyl and parafluorofentanyl were scheduled in 1980, followed by alfentanyl in 1984 and remifentanil in 1999. Quite obviously, this video analysis of fentanyl would not be complete without addressing its central role in the ongoing opioid crisis in the United States. To contextualize this issue, we must first consider the broader historical landscape of illicit opioid use in the United States, as the current crisis is not the nation's first. Illicit fentanyl use in the United States has escalated markedly since the early 2000s. One of the primary antecedents of this surge is the prescription opioid epidemic that emerged during the 1990s. However, it is important to note that the rise in prescription opioids did not create the black market for illicit opioids, as such markets had already been entrenched in US drug history for quite some time. The illicit opioid market has experienced cyclical fluctuations long before the wave of prescription opioid misuse. Following a post-World War II spike, opioid use was largely continued by the 1960s. A more substantial heroin epidemic emerged in the late 1960s and persisted into the mid-1970s, but was eventually mitigated through both demand-side strategies, such as the early implementation of methadone treatment, and supply-side interventions. Between the mid-1970s and mid-1990s, the heroin market remained unstable. Supply sources shifted rapidly from Mexico to Southwest Asia, then to Southeast Asia, and eventually to South America. During this period, heroin purity increased and correspondingly purity-adjusted prices declined. Nevertheless, initiation rates remained low, with use largely confined to an aging demographic of predominantly male users in urban centres across the northeast and southwest. Heroin remained relatively scarce in smaller cities and rural areas. This dynamic changed in the mid-1990s. A new wave of users whose opioid dependence began with prescription medications began transitioning to cheaper and more accessible illicit opioids, including heroin. Simultaneously, Mexico re-emerged as the primary source of heroin, eventually overtaking South America. From 2007 onwards, seizures of heroin along the US-Mexico border rose sharply. More recently, two new and highly consequential product forms, illicitly manufactured fentanyl and counterfeit opioid tablets, have become increasingly pervasive in North American drug markets. Today, the illicit opioid market in the US is saturated with fentanyl and its analogues. This is largely due to the compound's low production costs, ease of synthesis, and extreme potency. Even small quantities, which are easy to conceal and smuggle, yield substantial profits. Drug traffickers often blend fentanyl and its analogues with heroin or other opioids to enhance potency, frequently without user awareness. The sources of illicitly manufactured fentanyl are varied. A significant proportion is believed to originate from the same regions and potentially even the same facilities that produce legitimate pharmaceuticals. Numerous companies involved in the manufacture of fentanyl precursors are located in China. As shown in the accompanying diagram, these substances often traverse complex global supply chains. However, the DEA has identified a common trafficking route. Bulk shipments from China are delivered to Mexican drug trafficking organizations, which then transport the product across the US southwest border. Some of the fentanyl is also reportedly synthesized directly in Mexico. A smaller portion of the US illicit fentanyl supply originates in Canada, where precursors and analogues also imported from China are processed in clandestine laboratories. These labs may either distribute fentanyl within Canada or smuggle it across the northern US border. Within the United States, fentanyl may be sold directly or used to adulterate heroin and increasingly other illicit substances such as cocaine. This trend has been facilitated by a shift in the heroin market. Trafficking networks now commonly distribute powdered heroin as opposed to the more traditional black tar form, which is far more difficult to adulterate with synthetic opioids like fentanyl. To gain a broader perspective on the opioid crisis in the United States, consider the figure illustrating estimated global opioid-related mortality for 2024. As the data clearly show, the United States leads globally with an annual opioid overdose death rate of 15.4 per 100,000 individuals. Canada then follows, reporting 6.9 deaths per 100,000, while Russia records approximately 3 deaths per 100,000. In the US, the overwhelming majority of fatal opioid overdoses are directly associated with fentanyl and its highly potent analogues, most notably carfentanil. A similar trend is evident in Canada, where fentanyl and related compounds dominate the landscape of opioid-related fatalities. In contrast, Russia's opioid mortality is more commonly linked to desomorphine, a powerful heroin-like semi-synthetic opioid infamous for its toxic impurities. These impurities frequently cause severe tissue damage, including skin necrosis, and contribute significantly to the lethality of desomorphine and its derivatives. That said, emerging reports suggest that fentanyl and other potent synthetic opioids have begun infiltrating the Russian black market as well, often originating from China, mirroring the trafficking patterns observed in North America. However, reliable data from Russia remains limited. Official statistics should be interpreted with caution, as unfavorable public health indicators may be underreported or obscured for political reasons. Regardless, the mortality figures shown in the accompanying chart are drawn from the Global Burden of Disease study, conducted by the Institute for Health Metrics and Evaluation, a highly respected public health research institute affiliated with the University of Washington in Seattle. In recent years, concerns has intensified across the European Union regarding the proliferation of synthetic opioids, a crisis that has profoundly affected the United States over the past decade. As mentioned, Fentanyl has emerged as the primary driver of opioid-related overdose mortality in North America. Within Europe, prescription opioid consumption has steadily increased over the last 10 years, largely driven by rising prescription of tramadol and oxycodone. Today, the European opioid landscape is becoming increasingly complex, shaped by the diversion of pharmaceuticals, the presence of internationally controlled substances, and the emergence of highly potent synthetic opioids. As illustrated in the accompanying graph, which charts opioid-related overdose fatalities in the EU from 2009 to 2022, there has been a marked rise in deaths linked to synthetic opioids, particularly fentanyl and benzimidazole derivatives. These are fully synthetic compounds with pharmacological properties closely resembling those of fentanyl. The data show a notable spike in fentanyl-related fatalities during 2016 and 2018, after which benzimidols and other opioids, most notably heroin, became the dominant contributors to overdose deaths. By 2022, benzimidols represented the leading opioid class involved in lethal overdoses across the EU. On the European black market, fentanyl is available in diverse formulations, including nasal sprays, drops, lozenges, confectionaries, powders, and injectable solutions. It is frequently adulterated with or substituted for heroin, cocaine, or MDMA, and much of the illicit fentanyl in Europe is believed to originate from China. Following the Taliban's 2022 ban on opium production in Afghanistan, the quality of heroin trafficked into Europe has declined, leading to a surge in fentanyl availability across illicit markets. Estonia has long served as a cautionary case, having faced an entrenched fentanyl crisis since the early 2000s. There, heroin was effectively supplanted by fentanyl and its analogues, resulting in hundreds of overdose deaths and the establishment of sustained pattern of intravenous fentanyl use. More recently, 3-methylfentanyl and fentanyl itself have been marketed as heroin substitutes in countries with heroin shortages, including Bulgaria and Slovakia. Additionally, Germany, Finland, and the United Kingdom have reported new outbreaks of fentanyl-related fatalities. These developments underscore that within European context, fentanyls are characterized by low prevalence but high risk and harm. While Estonia remains an outlier with an endemic fentanyl problem, usage in other European countries appears geographically localized. The illicit supply chain reflects the broader complexities of Europe's contemporary drug market, encompassing illicit production and consumption, diversion and misuse of legitimate medicines, and the online distribution of uncontrolled new psychoactive substances. Unlike the US, where widespread medical prescribing of opioids have served as a key entry point to synthetic opioid misuse, Europe's more restrictive prescribing practices have thus far limited the primary at-risk population to heroin users and consumers of counterfeit or falsified medications. Nonetheless, with an estimated 1 million high-risk opioid users in Europe, any expansion of synthetic opioid use, whether through adulterated heroin, counterfeit pharmaceuticals, or a transition to fentanyl as seen in Estonia, has the potential to spread rapidly. As previously noted, fentanyl is a fully synthetic opioid with a potent central nervous system depressant and analgesic properties. Structurally, it belongs to the phenylpiperidine class, identifiable by its characteristic piperidine ring shown in the 2D molecular diagram to the right. Its molecular formula is C22H28N2O, comprising 22 carbon, 28 hydrogen, 2 nitrogen and 1 oxygen atom, with a molar mass of approximately 336.5 grams per mole. Fentanyl reportedly possesses 5 optical isomers, namely para, ortho, alpha, beta, and 4-methyl-acetylfentanyl, though literature on its stereochemistry is limited. So if any chemists or pharmacologists are watching, feel free to offer clarification. The compound exhibits a boiling point of 466 degrees Celsius at 1 atmosphere, and in terms of solubility, free-base fentanyl dissolves in organic solvents like alcohol, while fentanyl citrate, the most commonly used medical salt form, is readily soluble in water. Regarding synthesis, There are multiple synthetic routes to fentanyl, 3 of which are depicted in the figure to the right: Jenssen's, Gupta's, and Siegfried's methods, all of which begin with 4-piperidone as a core precursor. Among these, Gupta's method is the most commonly used, both in pharmaceutical settings and illicit labs, due to its relative simplicity and accessibility. Jenssen's original synthesis, while historically significant, is now considered overly complex, while Siegfried's method, though more streamlined than Jenssen's, is still more technically demanding and time-consuming, making it less common in illicit production. Let's now briefly explore fentanyl's pharmacokinetics. It's worth noting upfront that the data presented here may not be entirely consistent across sources, as several studies report conflicting findings. Additionally, the values discussed reflect medical use rather than recreational context. We will start with the basic pharmacokinetic parameters for transdermal, oral, and intravenous administration. The transdermal bioavailability reaches approximately 90%, while oral bioavailability varies from 30% for swallowed dose and up to 71% for buccal and sublingual formulations. On the other hand, intravenous bioavailability reaches 100% by definition. The time to maximum plasma concentration, or Tmax for short, ranges from 6 to 72 hours for transdermal formulations, depending on patch type, skin permeability, and individual variability. Moreover, Tmax for oral fentanyl is typically between 20 to 90 minutes, while for intravenous methods, it is around 5 minutes on average. Furthermore, the onset of action is between 6 to 12 hours for transdermal use, 2 to 15 minutes for oral use, and 30 to 90 seconds for intravenous administration. The duration of action for the transdermal delivery method often ranges between 48 and 72 hours, while for oral formulations it stands at 1 to 4 hours. On the other hand, intravenous administration provides similar duration of action, albeit with much faster onset of action. Regardless of selected administration method and formulation, fentanyl exhibits a high plasma protein binding profile of 86 to 89%, with 78% bound to albumin and around 12% to alpha-1 acid glycoprotein. Consequently, only 12 to 14% of fentanyl remains unbound and pharmacologically active, capable of crossing the blood-brain barrier and eliciting central effects. The biological half-life reaches around 17 hours for transdermal use and 7 hours for oral mode of administration. When used intravenously, fentanyl elimination half-life ranges between 2 to 4 hours, with an estimated average of 3 hours depending on the source used. Lastly, fentanyl is primarily metabolized hepatically, predominantly via CYP3A4 enzymes. Renal excretion is the main route of elimination, with the majority of metabolites excreted in urine and a smaller proportion via feces. Similar to other opioids, fentanyl functions as an agonist of opioid receptors. These include 3 primary types, namely MOR, DOR, and CORE. In a similar fashion to the previously mentioned opioids, fentanyl exhibits the strongest binding affinity for the MOR receptor, though it still engages with DOR and CORE receptors to a lesser extent. To better illustrate fentanyl's interaction with these receptors, let's refer to the figure on the right, depicting the opioid receptors, their intracellular signaling pathways, and corresponding psychophysiological outcomes. Before diving into these specifics, it's worth noting an additional receptor, the nociceptin opioid receptor, abbreviated as NOBR. Its endogenous ligand, nociceptin, acts as a neuromodulator involved in pain, anxiety, and cardiovascular regulation. However, NOBR receptor is not a significant target of fentanyl, so we will skip on this one for now. Now, when an agonist like fentanyl binds to an opioid receptor, it initiates intracellular signaling via 2 main pathways, the G-protein pathway and the beta-arrestin pathway. Some opioids show preference or bias toward one of these pathways, while others, known as balanced agonists, activate both simultaneously. These pathways yield distinct effects. G-protein signaling is primarily associated with analgesia, euphoria, and reinforcement, especially with chronic activation. In contrast, beta-arrestin signaling also produces analgesia, but is more often linked to adverse effects such as dysphoria and aversion. Fentanyl, as currently classified, is a balanced more-opioid receptor agonist, activating both pathways upon binding. This dual activation underlies its full spectrum of effects: potent analgesia, euphoria, sedation, high addiction potential, constipation, and notably respiratory depression. However, some studies suggest fentanyl may exhibit a slight bias toward beta-arrestin signaling, which could explain its propensity to cause respiratory depression even at therapeutic doses. Since beta-arrestin-biased opioids tend to have a narrower therapeutic window, compounds favoring G-protein or balanced activation are generally preferred in clinical contexts. Still, the prevailing literature continues to classify fentanyl as a balanced agonist, so we will proceed with that understanding for now. A key clinical concern of fentanyl is its tendency to cause respiratory depression with high therapeutic doses, which are still significantly lower than those used in recreational settings. For quite some time, it has been thought that this phenomenon stems from fentanyl's exceptionally high affinity and efficacy at more opioid receptors, contributing to its increased potency. After all, it is well established that potent opioids like diacetylmorphine, aka heroin, tend to produce a sign of respiratory depression even in medical settings when higher doses are used. To give you some perspective on the potency of this substance, fentanyl reportedly achieves 400 times greater intravenous potency than morphine. As such, fentanyl has been commonly characterized by some professionals as a superagonist of more opioid receptors. However, more contemporary research suggests that fentanyl's high potency does not purely stem from its enhanced more affinity and efficacy, as they are both comparable to morphine. Instead, recent evidence suggests that its pronounced lipophilicity, facilitating rapid and efficient blood-brain barrier penetration, is likely the primary factor behind its high potency. Moreover, this factor alone can also explain the rapid onset of action of this opioid. This property not only intensifies its therapeutic effects, but also raises the risk of respiratory depression, particularly given intra-individual variability in response. Therapeutic doses already potent may inadvertently suppress respiration in some individuals, a risk magnified in recreational settings. Finally, although fentanyl does interact with DOR and core receptors, its affinity for them is much weaker. DOR receptor engagement at higher doses can contribute to spinal analgesia, while core activation may induce dysphoria. In any case, these effects are secondary and typically emerge only at supratherapeutic doses. The previously mentioned activation of morphine opioid receptors by fentanyl triggers a cascade of neurobiological processes directly linked to its psychophysiological effects. As shown in the figure on the right, morphine receptor activation inhibits GABAergic projection between the rostromedial tegmental nucleus and the ventral tegmental area. This particular disinhibition leads to increased dopamine release along the mesocortical limbic pathway, projecting from the ventral tegmental area to the nucleus accumbens. Since morphine receptors are expressed on GABA interneurons, fentanyl suppresses GABA activity, thereby indirectly enhancing dopaminergic transmission, a mechanism commonly implicated in the reinforcing properties of opioids and the development of psychological dependence with repeated use. That said, emerging human research challenges this long-standing model. For example, studies have shown that morphine fails to significantly increase striatal dopamine in humans, while oxycodone does, albeit briefly. In any case, fentanyl is still generally understood to act through similar dopaminergic mechanisms as other full morphine opioid receptor agonists discussed in prior videos. In addition to dopaminergic changes, fentanyl-induced morphine opioid receptor activation also facilitates glutamatergic transmission. Over time, this contributes to maladaptive neuroplasticity and the formation of pathological associative learning, a key feature in opioid addiction. Unlike morphine, fentanyl induces minimal histamine release. As a result, histamine-mediated side effects such as itching are less prevalent with fentanyl compared to opioids like morphine or pethidine. Finally, Fentanyl interacts with P-glycoprotein, a membrane-bound transporter in the blood-brain barrier responsible for regulating the entry and exit of various compounds. Fentanyl serves as a substrate of P-glycoprotein, which facilitates its active efflux from the brain back into systematic circulation, accounting for its relative short duration of action. That said, co-administration of P-glycoprotein inhibitors can impair this clearance mechanism, potentially leading to elevated brain concentrations, prolonged pharmacological effects, or even overdose. Fentanyl is primarily metabolized in the liver, with a smaller contribution from intestinal metabolism. The main enzyme responsible for its biotransformation is CYP3A4, supported by CYP3A5, CYP3A7, and catechol O methyltransferase, abbreviated as COMT. Unlike heroin, which must first be converted into active metabolites like 6-monoacetylmorphine and morphine, fentanyl is pharmacologically active in its original form and does not depend on first-pass metabolism. Its primary metabolic pathway is N-dealkylation, producing norfentanyl, an inactive metabolite. This is the main route of clearance, accounting for nearly all of fentanyl's metabolism. As illustrated in the figure, there are some additional minor metabolic routes, including hydrolysis, hydroxylation, and O-monomethylation, that contribute less than 1% of the total biotransformation. All mentioned minor routes produce mostly inactive metabolites. However, 4-hydroxyfentanyl, formed via hydroxylation, stands out. That is because in animal models it produced opioid-like effects with potency between morphine and pethidine. In humans, this metabolite is further inactivated by hydroxylation and O-methylation catalyzed by COMT enzyme into 4-hydroxy-3-methoxyfentanyl, which is pharmacologically inert. Once metabolized, fentanyl is excreted primarily via the kidneys in urine, with minor elimination through bile and feces. Liver and enzymatic function significantly affect fentanyl metabolism. Co-administration with CYP3A4 inhibitors, such as certain medications or recreational drugs, can elevate plasma fentanyl levels, prolong its effects, and heighten the risk of opioid-induced respiratory depression. Similarly, discontinuing CYP3A4 inducers during fentanyl therapy may increase adverse effects. Although fentanyl is often preferred over morphine in patients with hepatic or renal impairment due to minimal active metabolite accumulation, its pharmacokinetics can still be altered by genetic variation in CYP3A4 expression or by food enzyme interactions. For instance, grapefruit, a potent CYP3A4 inhibitor, can interfere with fentanyl metabolism and increase its bioavailability. Age is another important factor. CYP3A4 activity varies across the lifespan, with infants generally exhibiting reduced enzymatic activity, while children aged 1 to 9 years often show enhanced CYP3A4 function compared to adults. As such, these developmental differences may impact both the rate of metabolism and the appropriate dosing of fentanyl across age groups. This time, we will focus on routes of administration for medical-grade fentanyl used in recreational settings, as it is considered the safest variant compared to illicit analogues. Illicit fentanyl, often sold as salts like hydrochloride or sulfate, poses extreme risks, with even brief skin contact potentially proving lethal in milligram range doses. While formal data is limited, anecdotal reports suggest that most recreational users tend to misuse pharmaceutical fentanyl, which is why this discussion will center on that form. To support this, I have included a table summarizing various medical fentanyl formulations ranging from buccal lozenges to sublingual spray. The table outlines administration routes, required onset times, bioavailability, onset of action, and dose strength. In any case, I will move to the possible administration methods of medical fentanyl in recreational settings. The first possible mode of use is the transdermal method, using transdermal fentanyl patches, which are designed for long-term pain management, often prescribed to cancer patients. Recreational users have occasionally resorted to tubing these patches, though this is highly unsafe. The medically appropriate and safest route is dermal application. These patches release fentanyl gradually through the skin, resulting in stable plasma levels. Fentanyl becomes detectable in serum within 1 to 2 hours, but therapeutic levels are typically reached only after 12 to 16 hours due to the saturation time required for the skin. Matrix patches come in doses of 12, 25, 50, 75 and 100 micrograms an hour and are replaced every 72 hours. Because of the slow onset and gradual absorption, this route is less appealing to recreational users, but it remains the safest option. Fentanyl is also available in oral transmucosal forms, including lozenges, sublingual tablets, and buccal tablets. These are primarily intended for breakthrough pain and are not to be used more than 4 times daily. Lozenges are available in 200 to 1,600 microgram doses. Approximately 25% of the drug is absorbed through the oral mucosa, while the remaining 75% is swallowed. Of that, only 1/3 bypasses first-pass metabolism for delayed intestinal absorption. This route offers a faster onset than transdermal administration and a shorter duration, with peak effects typically lasting between 1 to 3 hours. While relatively safe, the short-lived effects may encourage compulsive redosing, thus increasing the risk of overdose. The intranasal method of administration is also possible, thanks to delivery systems like intranasal spray. Intranasal fentanyl sprays are typically available in 100, 200, 400 or 800 microgram doses, with 8 sprays per unit. Though relatively rare in recreational settings, this route offers approximately 70% bioavailability. Compared to intravenous use, intranasal administration has a slower onset and shorter half-life. While the relatively quick effect may appeal to users, the brevity of action again raises the risk of repeated dosing. Overall, this method is less safe than oral routes and also less commonly abused. The intramuscular method is rarely used in recreational settings and is typically restricted to clinical environments. Onset of action occurs within 7 to 8 minutes, with effects lasting between 1 to 2 hours. Despite its legitimate medical applications, it presents a significant safety risk in unsupervised use. The last mode of use is the intravenous administration, which is extremely uncommon in recreational settings due to its high potency and rapid onset. Effects may occur within 1 minute, leaving little to no margin for error and dramatically increasing the risk of fatal overdose. This route is considered highly dangerous outside of controlled medical environments and is strongly discouraged. In order to provide historical context on fentanyl's rapid onset delivery systems, let's briefly examine this timeline illustrating the development of various administration methods for acute pain management. In 1968, intravenous fentanyl was first introduced into clinical practice. This was followed by the advent of transdermal patches in 1990, enabling non-invasive sustained-release administration. By 1993, the first fentanyl lozenges entered the market, later refined in 1998 to enhance their clinical utility. Unlike transdermal systems, lozenges allow for significantly faster onset of action, making them ideal for treating breakthrough pain. Subsequent innovations included buccal tablets in 2006, and buccal-soluble films shortly thereafter. In 2011, nasal fentanyl sprays were introduced, followed by sublingual sprays in 2012, both offering ultra-rapid absorption via mucosal membranes. Here we see a depiction of a transdermal patch containing 12 micrograms of fentanyl. These patches deliver the drug at a relatively constant rate. Upon initial application, serum fentanyl levels gradually rise, typically reaching therapeutic concentrations within 6 to 12 hours and achieving steady state levels within 12 to 24 hours. This concentration remains stable for up to 72 hours, with peak plasma levels occurring between 24 and 72 hours post-application. Pharmacokinetically, fentanyl's serum concentration correlates directly with patch size and dose. However, inter-individual variability exists, largely due to differences in skin permeability and systematic clearance. Notably, elevated skin temperature has been shown to enhance transdermal absorption. Currently, two primary designs of fentanyl patches are in clinical use: reservoir type and matrix type. The reservoir type consists of 4 layers: a backing film, a drug reservoir, a rate-controlling membrane, and an adhesive layer. The drug reservoir contains a mixture of fentanyl, ethanol, and hydroxyethyl cellulose, with ethanol serving as a permeation enhancer. Drug release is modulated by an ethylene vinyl acetate membrane, while a polysiloxane pressure-sensitive adhesive ensures adherence. The patch is protected by a silicified paper release liner removed before application. In contrast, the matrix type incorporates fentanyl directly into a self-adhesive acrylic polymer matrix. This colloidal layer is covered by a polypropylene protective film with waterproof properties and an anti-stick liner that must be peeled off before use. Drug release is controlled by the acrylic polymer, eliminating the need for a separate reservoir or a membrane. It's worth noting that some recreational users reportedly administer these patches via buccal or sublingual routes. While anecdotal evidence suggests that both methods can elicit psychoactive effects, they carry significant risks, most notably oral mucosal irritation, and are thus strongly discouraged. Now let's explore approximate dosing ranges for transdermal and intravenous fentanyl citrate in opioid-naive individuals based on anecdotal reports primarily from Arrowwood. As always, these figures are for educational purposes only and refer exclusively to pharmaceutical-grade fentanyl citrate, not illicit analogues of unknown purity or composition. Due to its extreme potency, fentanyl poses substantial risks, particularly outside of clinical supervision. It is unequivocally inadvisable to use this substance recreationally, as few substances carry a comparable risk-to-effect ratio. In any case, for medical reference, standard intravenous fentanyl dosing begins at 0.5 micrograms per kilogram, with high-end dosing reaching 2 micrograms per kilogram, the latter typically reserved for opioid-tolerant individuals undergoing treatment for severe or chronic pain. Recreational users, if experimenting, should begin in the low-dose range and escalate only with tolerance, though this practice remains extremely hazardous. Anyway, as for transdermal dosing of fentanyl in recreational settings, a threshold dose ranges from 10 to 25 micrograms. A low dose falls between 25 and 50 micrograms. The common or typical dose lies within 50 to 100 microgram range. A strong dose is considered to be 100 to 150 micrograms. A heavy dose ranges from 150 to 200 micrograms, while any dose exceeding 200 micrograms is classified as excessive and significantly increases the risk of adverse effects. In the context of intravenous administration, the threshold dose typically ranges from 5 to 10 micrograms. A low dose falls within 10 to 25 micrograms, while a standard or common dose lies between 25 and 50 micrograms. Doses between 50 and 100 micrograms are classified as strong, whereas a heavy dose is generally considered to range from 100 to 150 micrograms. Any dose exceeding 150 micrograms is then regarded as excessive and carries a markedly increased risk of toxicity. The LD50 in humans is not precisely established. However, anecdotal evidence suggests that 2 mg may be sufficient to induce fatal respiratory depression in 50% of individuals. For comparison, in non-human primates, the LD50 is approximately 0.03 mg per kilogram, highlighting fentanyl's narrow safety margin. Before moving forward, consider this image showing an approximate lethal dose of fentanyl in humans, alongside a US penny for scale. Now let's briefly address the timeframe of effects for both transdermal and intravenous fentanyl administration methods. Here, it is essential to note that effect timeframes, particularly for transdermal patches, can vary significantly across individuals. This variability is influenced by several physiological and environmental factors, including ambient and body temperature, skin salinity, perspiration, patch placement, subcutaneous fat content, patch formulation, and dosage. Moreover, Due to the limited availability of user reports on the transdermal mode of use in recreational settings, the presented timeframes are speculative and based largely on anecdotal interpretations. By contrast, timelines for intravenous administration are somewhat more reliable, as they are derived primarily from clinical literature, albeit with a focus on medical settings. As such, even these estimates may not fully reflect recreational context, where usage patterns differ considerably. With that caveat in mind, I will leave you to review the summarized displayed timelines at your convenience. The psychological effects of fentanyl vary significantly based on the selected route of administration, dosage, and individual differences. While lower doses delivered transdermally tend to produce mild mood enhancement, mental relaxation, and a modest reduction in social inhibitions, the high intravenous dose can elicit an intense euphoric rush, which is then rapidly followed by pronounced mental sedation. Overall, fentanyl's positive psychological effects may include elevated mood, euphoria, anxiety reduction, mental relaxation, and increased sociability. Neutral effects then often comprise drowsiness and enhanced dream vividness. Conversely, negative psychological effects may involve compulsive redosing, ego inflation, irritability, delusion of sobriety, and reduced cognitive acuity. Similar to its psychological profile, the physiological effects of fentanyl vary in intensity depending on the route of administration, dosage, and individual differences. While lower doses generally induce mild muscle relaxation and moderate analgesia, the higher doses typically produce pronounced physical euphoria, often described as a warm, full-body sensation accompanied by intense muscle relaxation and tingling sensation. Altogether, the positive physiological effects include potent analgesia, physical euphoria, cough suppression, and muscular relaxation. Neutral effects may then include pupil constriction, increased perspiration, appetite suppression, urinary retention, dry mouth, and bradycardia. On the other hand, negative effects may encompass excessive central nervous system depression, constipation, dehydration, hypotension, nausea, vomiting, and orgasm suppression. As with many other substances of abuse, both acute and chronic fentanyl use is linked to a broad spectrum of adverse physiological effects. These range from respiratory depression, which impairs pulmonary function, to cardiac complications such as QT interval prolongation, a condition where ventricular repolarization is delayed between heartbeats. This can precipitate life-threatening arrhythmias, including torsades de pointes, which may culminate in sudden cardiac arrest. In any case, if you're interested, I will let you explore the full range of side effects. However, for now, let's move on to the next section, where we will focus on visual disturbances and other subjective effects associated with fentanyl use. In rare cases, fentanyl may elicit a range of atypical effects, including blurred vision, internal hallucinations, and a sense of dissociation. Blurred vision is typically observed at higher doses and is characterized by involuntary shifts in ocular focus, likely resulting from disrupted depth perception. Notably, this phenomenon can sometimes be mitigated by occluding one eye, suggesting monocular compensation. Internal hallucinations are also predominantly associated with elevated doses, often present as hypnagogic states marked by vivid, dreamlike imagery and abstract geometric forms. The semi-conscious episodes may be further intensified when fentanyl is co-administered with cannabinoids, dissociatives, or psychedelics. Anecdotal evidence then indicates that fentanyl alone is capable of inducing level-3 internal hallucinations at strong to heavy recreational doses. Moreover, the associated sense of dissociation, while generally less pronounced than that induced by classical dissociatives such as ketamine, still remains quite prominent. This effect appears to stem from fentanyl's profound sedative properties, which can produce a fluctuating state of consciousness, commonly described as drifting in and out of consciousness. As with the internal hallucinations, dissociative sensation may be potentiated through synergetic interactions with cannabinoids, dissociatives, or certain sedative psychedelics like LSD. Fentanyl withdrawal typically begins within 3 to 6 hours after the last dose, and like other opioids, induces both psychological and physiological dependence. The severity of withdrawal ranges from moderate to severe and is influenced by factors such as duration of use, daily dosage, and individual variability. Clinical observations indicate that individuals with opioid use disorder often describe fentanyl withdrawal as more intense, longer lasting, and faster in onset than heroin withdrawal. Due to fentanyl's high lipophilicity, it can accumulate in adipose tissue, leading to delayed systematic clearance. This may result in detectable fentanyl levels several days after cessation. For example, one study of individuals in a 28-day residential program found that fentanyl remained detectable for an average of 7.43 days, with some cases persisting up to 19 days post-admission. As illustrated in the adjusted figure, fentanyl withdrawal syndrome unfolds in 3 stages. The first phase, called acute phase, is characterized by intense symptoms such as cravings and muscle aches. This stage typically resolves within 1 to 3 days when professionally managed. In some cases, medical detoxification with long-acting opioids like methadone or buprenorphine is necessary to reduce symptom severity. Another phase, called post-acute phase, lasts between 1 to 2 weeks and is marked by a decline in symptoms, although some psychophysiological effects may still persist. The last phase, called protracted withdrawal syndrome, may last months to years, particularly in long-term users. Symptoms often include persistent cravings, dysphoria, and impaired cognitive control, increasing the risk of relapse, especially under stress. Treatment strategies typically involve opioid replacement therapy to mitigate cravings following detox. Long-acting opioids like methadone or buprenorphine administered under clinical supervision help stabilize withdrawal symptoms more efficiently than short-acting opioids. Dosing of these opioids is typically individualized, with a gradual taper once stability is achieved. The maintenance phase may span months, years, or even a lifetime, depending on the severity of dependence. While some clinicians attempt to taper off after 1 year, others advocate for lifelong treatment due to the high risk of relapse and overdose post-cessation. If treatment discontinuation is pursued, it should be done gradually, with adjustments based on symptom presentation. Psychotherapeutic interventions such as cognitive behavioral therapy and group therapy are often integrated with opioid replacement therapy to improve outcomes. Cognitive behavioral therapy focuses on relapse prevention and is most effective when combined with pharmacotherapy. Group therapy, though generally less effective as a standalone treatment, enhances self-regulation and is more cost-effective. Its efficacy also improves when used alongside medication-based treatment. This figure presents a general overview of the neurobiological mechanisms underlying the development and maintenance of addiction and withdrawal. In the case of fentanyl, these processes closely mirror those observed with other opioids and addictive substances in general. In brief, chronic fentanyl exposure leads to the downregulation and desensitization of postsynaptic dopaminergic receptors, accompanied by a reduction in endogenous opioid activity, particularly beta-endorphins. Additionally, sustained fentanyl use suppresses noradrenergic activity and disrupts neuroendocrine homeostasis, affecting both anti-stress and stress-related neurotransmitter systems, as illustrated in the figure. Upon abrupt discontinuation, the locus coeruleus becomes hyperactive, releasing excessive noradrenaline, which triggers many of the autonomic and psychophysiological symptoms characteristic of opioid withdrawal. Concurrently, dopaminergic activity sharply declines, as the system, having adapted to fentanyl's presence, is no longer capable of producing sufficient dopaminergic activity endogenously. The opioid system also becomes destabilized. Due to marked reduction in beta-endorphin activity, fentanyl effectively replaces this neuropeptide as the primary agonist for morphine opioid receptors. Without fentanyl, morphine opioid receptor activation ceases, exacerbating withdrawal symptoms. Simultaneously, the brain, attempting to counterbalance prolonged morphine opioid receptor stimulation, upregulates dynorphin, an endogenous agonist of kappa opioid receptors. After fentanyl cessation, elevated norphine levels persist, inhibiting dopaminergic activity further and intensifying dysphoria and anhedonia. Moreover, withdrawal is compounded by an upsurge in corticotrophin-releasing factor hormone, which hyperactivates the hypothalamic-pituitary adrenal axis, thereby heightening stress response and contributing to additional withdrawal symptoms. Together, these interacting neuroadaptations underlie the pathophysiology of fentanyl addiction and withdrawal. Fortunately, following cessation, these dysregulated systems begin to normalize over time as the brain gradually restores its neurochemical equilibrium. However, long-term neuroplastic changes, particularly those involving glutamatergic projection, may persist and are strongly implicated in relapse vulnerability due to their association with prolonged drug craving. Therefore, comprehensive and well-managed withdrawal treatment is essential not only to ease acute symptoms but also to facilitate long-term recovery and reduce the risk of relapse. This figure illustrates several common psychophysiological manifestations of fentanyl withdrawal syndrome, spanning from intense drug cravings to muscle pain. While the symptom profile closely mirrors that of withdrawal from other opioids, fentanyl withdrawal is generally characterized by greater severity and intensity of these symptoms. Fentanyl, like many other substances, engages in pharmacodynamic and pharmacokinetic interactions with various other compounds, interactions that often yield adverse or hazardous outcomes. In this section, we will briefly explore some notable drug-to-drug interactions involving fentanyl. Caffeine and nicotine, while legally accessible and commonly consumed, they do not appear to produce life-threatening synergetic effects when used concurrently with fentanyl. However, studies suggest that caffeine may potentiate the analgesic effects of certain opioids such as tramadol. Conversely, nicotine has been associated with an increased susceptibility to opioid addiction, potentially facilitating the progression toward opioid use disorder. In contrast, co-administration of fentanyl with alcohol presents a significant elevated risk. That is because both substances potentiate central nervous system depression, thus greatly increasing the likelihood of fatal respiratory depression. Regarding kratom, its alkaloids, most notably mitragynine, are known to inhibit CYP3A4 enzymes, a critical hepatic enzyme responsible for metabolizing fentanyl. This metabolic interference can elevate fentanyl plasma concentrations, leading to respiratory depression even at otherwise non-lethal doses. Cannabinoids, when used concurrently with fentanyl, may enhance sedative effects, impairing motor coordination and increasing the risk of accidental injury. Central nervous system stimulants such as cocaine and amphetamines pose a different set of dangers. By blunting the subjective effects of fentanyl or vice versa, they can induce a false sense of sobriety, often culminating in compulsive redosing and unintentional overdose. Notably, there are documented instances of serotonin syndrome resulting from the combined use of fentanyl with high doses of stimulants, particularly those that affect serotonergic transmission. While serotonin syndrome is not invariably fatal, it can be life-threatening if left unmanaged. Fentanyl indirectly increases synaptic serotonin, while stimulants like methamphetamine or cocaine directly promote serotonin release or inhibit its reuptake, thus compounding the risk. Empathogens such as MDMA present a similar hazard profile. Like stimulants, they may mask opioid effects and amplify the risk of serotonin syndrome. Additionally, high dose of MDMA can inhibit CYP3A4 enzymatic activity, thereby impeding fentanyl metabolism and increasing systematic fentanyl accumulation, which raises the potential for overdose. Central nervous system depressants, including benzodiazepines, barbiturates, and tranquilizers, exert additive sedative effects when combined with fentanyl. This synergism significantly increases the risk of respiratory arrest. Dissociatives such as ketamine and phencyclidine also exhibit cumulative depressive effects when administered alongside fentanyl, though typically to a lesser extent than traditional CNS depressants. As for psychedelics, the literature remains sparse regarding their direct interaction with fentanyl. However, anecdotal evidence, often derived from user reports combining LSD with opioids, suggests that fentanyl may attenuate psychedelic intensity, possibly dampen visual and cognitive phenomena and shift them toward a more hypnagogic character. Moreover, certain psychedelics, such as alpha-methyltryptamine, which promotes serotonin release, may also provoke serotonin syndrome when used concurrently with fentanyl. Antidepressants, particularly SSRIs and monoamine inhibitors, elevate serotonin levels. Their combined use with fentanyl may precipitate serotonin syndrome. Additionally, agents like fluoxetine are known to moderately inhibit CYP3A4 enzymatic activity, thereby slowing fentanyl metabolic rate and increasing its systematic concentration. Finally, antipsychotics frequently inhibit CYP3A4 activity, thereby compromising fentanyl metabolism and amplifying overdose risk. Moreover, many antipsychotics exhibit sedative properties, further compounding fentanyl's CNS depressant effects. In summary then, in alignment with harm reduction principles, concurrent use of fentanyl with any other psychoactive substance, even those with a comparatively low interaction profile, like caffeine, is strongly discouraged. The pharmacological unpredictability and potential for synergetic toxicity warrant extreme caution. Before we wrap up, let's briefly examine the psychological and physiological indicators of a fentanyl overdose. On the psychological side, individuals may present with euphoria, dysphoria, marked drowsiness, or a significant depressed mood. These manifestations can vary in intensity depending on dosage and individual susceptibility. Physiologically, symptoms often include vomiting, bradypnea, respiratory depression, and in some cases cyanosis, that is, skin discoloration due to inadequate oxygenation. And of course, this is not an exhaustive list of all psychophysiological effects associated with fentanyl overdose. Instead, these are among the more frequently reported and observable signs. The accompanying figure to the right offers a visual summary of fentanyl's general effects alongside key symptoms indicative of overdose. This resource may serve as a quick reference tool for identifying individuals at potential risk. In such cases, emergency medical assistance should be sought without delay, and basic first aid should be administered while awaiting professional care. Anyway, that's it for today's topic. If you found this video helpful or informative, don't forget to like and subscribe. For those of you passionate about harm reduction and drug education, check out our dedicated portal, the Drug Library. You'll find the link down in the description. In the next video, we'll be diving into one of the most iconic classical psychedelics, lysergic acid diethylamide, better known as LSD. Also, before parting our ways, if you've got questions, thoughts, or just want to share your perspective, feel free to leave a comment below. Thanks for watching, and take care and stay safe.